Please start, ma'am. We are live.
A very warm welcome to all the faculties present in here to the multidisciplinary approach in GI and ESCC cancers. I welcome each esteemed faculty and our program leader, Dr. Lipashi Kurudam, Senior Consultant Medical Oncologist, Narayana Health Mysore, and Kagunadi Cancer Clinics, Karnataka. So kindly facilitate and begin the session with their opening remarks. Thank you.
Thank you, Arjan team. Good evening, all. Warm welcome to this webinar on recent advances in esophageal and GI cancer management. This webinar is mainly focused on recent GI oncology, especially Metron trial, that is the addition of immunotherapy drug durvalumab to standard flat chemotherapy in non-metastatic G junction or gastric adenocarcinoma showed significant survival benefit, and it is the first immunotherapy drug approved in non-metastatic gastric patients. And also another immunotherapy drug called nivolumab adjuvant therapy in residual esophageal squamous cell carcinoma post neoadjuvant chemoradiation and can survival benefit based on Checkmate 577 trial. And to discuss the major breakthroughs in GI oncology, we are with us esteemed speakers. They are going to discuss on these recent advances in the management of esophageal and GI cancer, and also some of the recent advances in the surgical management of GI and esophageal cancers, and also targeted therapies in both non-metastatic and metastatic esophageal and GI junction or gastric adenocarcinoma. Without much delay, I warmly welcome our esteemed speakers. Firstly, my teacher, mentor, and senior medical oncologist and lead of onco sciences in Karnataka Hospital, Bangalore. And I also want to welcome my friend, Dr. Ullas Baga. He is a surgeon and robotic surgeon at Hyderabad. Also welcome Dr. Sandeep KS. He is my friend, doing a lot of work at Raichur. And I also welcome Dr. Medical Oncologist from Mysore and Dr. Rajil Rajan, Medical Oncologist from Mysore. And I also like to welcome our sponsors of today's webinar, Glenmark Pharmaceuticals, AstraZeneca, Zydus, and NATCO, and also Origin Conference team led by Mr. Tarun Mathur. I hope this webinar is going to be a great learning for all of us. And I request audience submit your questions on chat box and interact with our speakers after the each session. Once again, welcome you all. And today is International Yoga Day. I also wish happy International Yoga Day and also Father's Day. Without further delay, we would like to start our webinar. So, urgent team to welcome and introduce our first speaker. Over to you, madam.
Now inviting Dr. Ullas Baga, oncology and robotic surgeon at Hyderabad, for the very first session of the meeting. Over to Dr. Ullas.
Yeah. Thank you, Dr. Lepakshi and the organizing team for inviting me to speak on advances in surgical management in GI cancers. Resharing my PPT. Is my PPT visible?
Yes, sir.
It is visible?
Yes, sir.
Okay. The slides are visible?
Yes, sir.
Okay.
So you can just scroll down, go to next.
Yeah. Advances in
Let-
surgical management
No,
of
sir,
GI.
it has again gone. Your slides are not visible now.
Okay. I need to click on the share.
Yes, sir. Yes, sir.
Yeah, I've clicked. It's not showing.
Can we share it from our side?
Yeah, you
How,
can. Yeah.
how do we have the sir slides? Can you share it? Yeah, it's coming, sir. Is it visible, sir, to you?
Yeah, it is visible.
Okay.
Can I move the slides?
No, sir. You just need to say next.
Okay,
So
fine.
the person who is sharing will move the slide.
Yeah, fine. Hello, I'm Dr. Ulas Paga, consultant surgical oncologist from DDH Renova Cancer Center, Hyderabad. I'm assigned a topic on advances in surgical management of GI cancers. Next slide. Before starting on to the proper topic, global burden of the GI cancers. GI cancers include cancers of esophagus, stomach, colorectum, and HPV cancers, along with the small intestine and anorectal cancers. They represent one of the largest contributors to the global cancer morbidity and mortality. As per the Globocon 2022, approximately 4.9 million new GI cancers were diagnosed in the worldwide in 2022. Out of that, 3.4 million deaths occur from the GI cancers. GI cancers account for about 25% of all cancer cases and 33% of all cancer deaths globally. Next. Surgical management of GI cancers has undergone major advancements over the past 2 decades. Improvements in the minimal invasive techniques, precision surgery, multidisciplinary care, and perioperative management have significantly enhanced patient outcomes while reducing complications. Next slide, please. When it comes to minimally invasive surgery, laparoscopic surgery is one of the main modality. Laparoscopic techniques are now widely used for many of the GI malignancies, including colorectal, gastric cancers, and selected pancreatic cancers. What are the advantages of this laparoscopic surgery? Smaller incision, reduced postoperative pain, shorter hospital stay, faster recovery, comparable oncological outcomes to the open surgery. Next. One more modality in the minimal invasive surgery is robotic assisted surgery. Robotic platforms provide three-dimensional visualization, enhanced dexterity, improved precision in confined anatomical spaces, especially in the pelvic surgeries where we do a lot of mid and lower rectal surgeries. Robotic surgery has changed our surgical aspects in that. Applications include rectal surgery, esophageal cancer surgery, gastric cancer surgeries, and pancreatic resections. Next slide, please. Principles of the surgical oncology remains the same, irrespective of it is open surgery, laparoscopic surgery, or the robotic surgery. The main principles being R0 resection, adequate lymphadenectomy, clear margins, multidisciplinary approach. Next slide. One of the most important development in the GI cancers is the ERAS protocol. The ERAS protocol means the enhanced recovery after surgery. The protocol is an evidence-based multidisciplinary care pathway designed to minimize physiological stress during surgery, accelerate recovery, and reduce hospital stays. It is widely used across various surgical specialties globally. Next slide, please. The components of the ERAS protocol includes it starts before surgery, that is pre-operative care, intraoperative, and a post-operative. What are the advances in the pre-operative? Pre-operative nutrition is one of the most important factors. When we operate a lot of cases on GI surgery, especially esophageal cancers, patients, most of them are malnourished. We need to improve the nutrition for the better outcomes. Prehabilitation, that is improving the nutrition, preparing the patient for the major surgery, and patient education and counseling. What are the surgical aspects? What will be the prognosis? How will be the recovery? And most important factor is cessation of the smoking and alcohol, multidisciplinary team approach, cardiopulmonary assessment, venous thromboprophylaxis, and preoperative fasting, which was earlier we used to keep the patients for a prolonged fasting, which has been cut down now with the carbohydrate rich loading prior to surgery. When it comes to intraoperative procedures, surgical approach, whether based upon the patient fitness, whether he is fit enough for anesthesia, whether the open surgery is beneficial, laparoscopic beneficial, we need to assess the patient. Anesthetic management and perioperative fluid management is also one of the most important factor. And intraoperative, another most important factor is prevention of hypothermia, which has a lethal effects post-operatively. When it comes to post-operative management, early mobilization, early removal of the drains, early enteral feeding, perioperative pain control, post-operative nausea and vomiting control, and a post-operative glycemic control. These are the important components of the ERAS protocol, which we follow routinely in the GI cancer surgeries. Next slide, please. One more important update in the GI surgeries: precision and image guided surgeries. Fluorescence guided surgery, that is, use of the near infrared imaging using indocyanine green, helps assess the tissue perfusion, identify lymphatic drainage pathway, detect the occult lesions. Intraoperative navigation helps in accurate tumor localization. Advanced imaging technology facilitates better margin assessment, preservation of the critical structures. Next slide, please. With the help of the near infrared imaging, and indocyanine green, the gold standard for the real-time localization, the microdose of the ICG is injected percutaneously into the inguinal lymph nodes or enterally. With the help of the NIR camera, surgeon can view the duct glowing bright green, making it exact trajectory highly visible through overlying tissues. Especially this will be helpful in our esophageal surgeries, identifying the thoracic duct. Minor leak of the thoracic duct can lead to chylothorax and post-operative significant morbidity, which has been overcome with the help of this near infrared imaging and ICG technique. Next slide. ICG angiography is a technique used intraoperatively to evaluate the real-time microperfusion at the site of anastomosis. Especially when we do anastomosis, in the colorectal anastomosis, the vascularity of the distal most end of the bowel is most important. If the ICG is not visible at that point, that means it is a poor perfusion. We have post-operative high chances of leak, which is overcome with the help of the ICG techniques. By injecting ICG intravenously, surgeons can identify poorly perfused tissue and adjust the resection margin, which helps prevent severe complications like anastomotic leaks. Next slide. How the technique works: the dye is administration, that is orogreen, that is contains the ICG. A small dose of ICG, typically 0.1 to 0.25 mg per kg, is injected intravenously by the anesthetist. The dye binds to the plasmaproteins and emits the fluorescent signal when excited by a near infrared camera. Especially the Firefly system on the robotic platforms will be able to see the green light. Within seconds to minutes, the surgeon can visualize the perfusion of the tissues, confirming healthy, well perfused bowel segments which glow brightly versus the ischemic tissues. Next slide. These are the two examples where on the first image it is showing the thoracic duct lighted with the green, identified and ligated, especially doing the transthoracic esophagectomy. And in the second image, it is the assessment of the intestinal perfusion before anastomosis. where it is showing in the second image after ICG injection, the distal most bowel is not healthy. So it will help us to revise the margin and identify the stump with a better perfusion. Next slide. So these are the SAGES guidelines for the fluorescence image guided surgery using indocyanine green and gastrointestinal procedures. There's a strong recommendation is you use for the primary tumor identification, lymph node identification, especially in the left side colorectal anastomosis, where the perfusion is better identified with the help of ICG. Some of the conditional recommendations are distant metastasis identification, and also it can be used in the esophageal anastomosis for the proper perfusion of the gastric conduit. And the reasonable intraoperative option could be thoracic identification, bariatric anastomosis, and pull-through procedures in the pediatric cases. Next slide. So what are the advances in the esophageal cancer? Recent esophageal cancers has shifted heavily towards the minimal invasive esophagectomy and robotic assisted minimally invasive esophagectomies. And these advances techniques significantly reduce surgical trauma, especially the post-operative pain, and decrease in the post-operative pulmonary complication and accelerate patient recovery compared to the traditional open surgeries. Next slide, please. Robotic assisted surgery, that is RAMI, provides surgeon with a 3D visualization, tremor filtration, and high dexterity instruments. This allows for a precise anatomical dissection and improved mediastinal lymphadenectomy in a very confined spaces. Next slide. This is the image depicting the robotic mobilization of the thoracic portion of the esophagectomy. These are the port position, camera, arm 1, arm 2, assistant ports, and in additional arm 3. This is showing in the subsequent picture, it is showing the thoracic mobilization of the esophagus. Next slide, please. This is the same gastric conduit preparation while doing the esophagectomy with the help of the endo-GI staplers, which is a new armamentarium for the surgeons. With the help of these endo-GI staplers, the work has been done very easy. Next slide, please. Comparison of the robotic assisted minimally invasive esophagectomy versus minimally invasive esophagectomy like laparoscopy. The conclusion shows that robotic assisted minimally invasive esophagectomy results in a higher lymph node yield compared to laparoscopic minimally invasive surgery. But there is no statistical significance between the overall survival or a DFS. Next slide, please. This is again the image showing the mobilization of the stomach and preparation of the conduit. Next slide. Now coming on to the advances in the gastric cancer surgery. Gastric cancer surgery is seen a lot of in southern part of India, where proper D2 lymphadenectomy is the standard of care. D2 lymphadenectomy standardization is most important. Improved surgical technique, training, and centralization have made extensive lymph node dissection safer. Next slide, please. This is the image showing, first image is showing the D1 lymphadenectomy and second image is showing the D2 lymphadenectomy. D1 lymph nodes these are the perigastric group of lymph nodes. D2 is the lymph nodes along the named vessel, that is the celiac group of lymph nodes, common hepatic group of lymph nodes, splenic lymph nodes, and supramesenteric lymph nodes. Clearing of these lymph nodes is the most important, and initially it was done with a lot of morbidity. Now with the exclusive training and with the help of the minimal invasive surgery, these procedures are done now with a lot of ease and safety. Next slide. Now coming on to the advances in the colorectal cancer surgery. When it comes to colorectal surgery, permanent stoma, ileostomy, these have been important drawbacks when it comes to these surgeries. But with the advent of this TME, TATME, and complete mesocolic excision, these surgeries are done routinely with a lot of safety. total mesorectal excision is one of the gold standard for a rectal cancer surgery. It reduces the local recurrence rate. If we don't follow the principles of TME, the chances of local recurrences are high, where ultimately patient will have to undergo APR and undergo a permanent stoma. One more new addition to low rectal cancers is a transanal total mesorectal excision. This offers a better visualization in the narrow pelvis, improved access to the low rectal tumors. This technique is used especially for the low rectal cancers, 4 to 5 centimeters from the anal verge, superficial lesions, where we can visualize better with the help of the TATME. And one more component is a complete mesocolic excision. When it comes to the right colon or it is the left colon, improves oncological clearance through a meticulous dissection along the embryological planes. Next slide, please. First image shows a complete mesorectal excision. It envelopes along the mesorectum so that there is lesser chances of the local recurrences. And the next image shows the TATME image, that is the transanal total mesorectal excision, especially for the low rectal cancers. Next slide, please. When it comes to the rectal cancer surgery, one of the most important of late is the organ preservation strategies. For selected rectal cancer patients, watch and wait approach proposed by Habergama, a Brazilian scientist and a doctor, has proposed a watch and wait approach. Patients achieving complete clinical response after neoadjuvant chemoradiation may completely avoid surgery, and these patients are completely kept on a close follow-up with the investigations like colonoscopy, MRI frequently. Potential benefits are avoidance of the permanent stoma, better bowel function, improved quality of life. Careful surveillance is the most important component in this watch and wait approach. Next slide. When it comes to advances in the hepatobiliary surgery, parenchymal sparing liver resections preserves the functional liver tissue while achieving oncological clearances. One of the most important component is the ALPS, associating liver partition and a portal vein ligation for a staged hepatectomy, allows resection of the extensive liver tumors previously considered unresectable. Laparoscopy and robotic liver surgery increasingly used in HCC and the colorectal liver metastasis. Next slide, please. When it comes to advances in the pancreatic cancer surgery, vascular resection and reconstruction has been most important. Earlier, head of the pancreas tumor infiltrating or invading the superior mesenteric vein less than 180 degree or more than 180 degree were declared as inoperable. Now, with the advances in the vascular resection of the portal vein and reconstruction, selected patients with a locally advanced disease can undergo these portal vein resection, superior mesenteric vein reconstruction at ease. Minimally invasive pancreatectomy includes a laparoscopic distal pancreatectomy and robotic pancreatoduodenectomies. Next slide, please. Now, artificial intelligence and a digital surgery have come up in a big way. Emerging applications include automated image analysis, surgical navigation systems, intraoperative decision support, predictive modeling for the complications. AI-assisted surgeries may improve precision and standardization in the future. Next slide, please. Personalized and multidisciplinary surgical oncology. Modern GI cancer care increasingly relies on molecular tumor profiling, multidisciplinary tumor boards, individualized treatment planning. Surgery is now often integrated with the targeted therapies, immunotherapy, neoadjuvant, and adjuvant treatments. Next slide, please. Now, one more important thing in the GI cancer is the role of HIPEC and PIPEC in a GI cancers. Peritoneal metastasis from the GI cancer was traditionally considered a terminal condition managed with systemic chemotherapy alone. The development of the cytoreductive surgery combined with a HIPEC and more recently PIPEC has expanded treatment option for a selected patients. Next slide, please.
Sorry for the interruption, sir. Kindly conclude the session in next 2 minutes.
I didn't get you.
Sir, kindly conclude the
No,
session.
no, 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 no. Let him continue.
Yeah, thank you.
Okay, sir.
HIPEC involves complete or near complete cytoreductive surgery to remove visible peritoneal diseases. Circulation of the heated chemotherapy at the temperature of 41 to 43 degrees centigrade within the peritoneal cavity for 30 to 120 minutes. The rationale for HIPEC being direct delivery of a high drug concentration to the peritoneal surfaces. It limits the systemic toxicity. Hyperthermia enhances chemotherapy penetration, increases cytotoxicity, improves tumor cell kill, impairs DNA repair mechanisms. Next slide, please. What are the common drugs used in HIPEC, especially in colorectal cancer surgeries? Mitomycin C and oxaliplatin are used. When it comes to gastric cancer, cisplatin, mitomycin C. When it comes to appendiceal tumors, mitomycin C is used. Mesotheliomas are another disease where you use HIPEC. Cisplatin and doxorubicin are the drugs used. Next slide, please. What are the indications for HIPEC in GI cancer? Colorectal cancer, has an established role. Selected patients with isolated peritoneal disease, low volume disease, good performance status, HIPEC can be used in these settings. The landmark Verval trial demonstrated survival benefit compared to systemic chemotherapy alone. Selected patients should have the PCR, that is the peritoneal carcinomatosis index should be less than 10 to 15. With a high burden disease, HIPEC is not indicated. Complete cytoreduction is must. CRS is considered standard in selected patients. Next slide, please. When it comes to gastric cancer, the role of HIPEC remains controversial. The benefits include improved regional disease control, potential survival benefit in highly selected patients, though guidelines are not established in this cancer still. Next slide, please. One more important area of use of HIPEC is appendiceal tumors and pseudomyxoma peritoneae, gold standard, particularly effective in a low-grade appendiceal mucinous neoplasm and pseudomyxoma peritoneae, where systemic chemotherapy is not much effective in these cases. 5-year survival often exceeds 70 to 80% after complete CRS and HIPEC in a pseudomyxoma peritoneae cases. Next slide, please. What are the major limitations of a HIPEC? It is a major surgery. Morbidity amounts 20 to 40%. We need a good perioperative supporting team, anesthetist, critical care physician to prevent the patients from going into complications. Mortality rates are still high to the tune of 1 to 5%. Long operating procedures require specialized centers. Benefit depends heavily on the complete cytoreductive surgery. Next slide, please. PIPEC, that is a pressurized intraperitoneal aerosol chemotherapy. It is a minimally invasive laparoscopic technique in which the chemotherapy is aerosolized, delivered under the pressure of 12 to 15 mm of Hg, distributed uniformly within the peritoneal cavity. Mechanism and advantages are improved tissue penetration, better spatial distribution, repeated administration possible with PIPEC, lower systemic toxicity, suitable for unresectable peritoneal metastasis. Next slide, please. PIPEC is useful in unresectable peritoneal metastasis, recurrent disease, positive peritoneal cytology. The goals being the tumor regression, symptom control, disease stabilization, improved quality of life. Next slide, please. When you compare HIPEC versus PIPEC, HIPEC requires a major CRS required, whereas PIPEC is a laparoscopic procedure. Repeatability, HIPEC cannot be repeated. PIPEC can be used as frequently as every 6 to 8 weeks. The morbidity in HIPEC is higher, PIPEC is lower. Hospital stay for the HIPEC is longer, shorter for the PIPEC procedure. In HIPEC, when the disease is unresectable, the role is very limited, but PIPEC is useful. The intent for use of PIPEC is palliative use. Next slide, please. The two ways to deliver chemotherapy directly into the abdomen. These are the pictorial depiction of the heated chemotherapy versus the pressurized aerosol chemotherapy. Next slide, please. coming on to the conclusion, the surgical management of GI cancers has evolved from a traditional open resection to highly sophisticated, minimal invasive, and personalized approaches. Innovations such as robotic surgery, fluorescent guided imaging, ERAS protocols, CRS, HIPEC, and PIPEC, along with organ preserving strategies and integration with the systemic therapies have improved oncological outcomes, reduced morbidity, and enhanced quality of life. Future developments in AI, molecular diagnostics, and image guided surgery are expected to further transform GI cancer surgery. Thank you.
Thank you so much, sir, for the insightful session. Now, as we can see, there are some questions from the doctors in the chat box. Now, I request Ms. Dr. Lepakshi to kindly address those questions.
Thank you, Dr. Ullas, for excellent presentation on recent advances in surgical management of GI cancers.
Thank you
It is
so
very useful for our residents because you covered extensively, even from the basic to advanced techniques. Just there are few questions from the residents. How is CRS or IPEC helpful in GI onco, especially in patients with peritoneal mets? And what will be the cost?
When it comes to GI cancers, the established rule has been already seen in ovarian malignancies. Particularly when it comes to GI malignancies, the PCI index should be very low. If there is extensive peritoneal disease, then the benefit is less. When a limited peritoneal disease with PCI index of 12 to 15 in a colorectal metastasis, the role of CRS and HIPEC is shown a better benefit with the help of that trial. And cost depends upon the hospital setup. HIPEC per se doesn't cost much. Most of the hospital centers do not have a HIPEC machine. Though these things are available on a rental basis, they usually charge somewhere around 1 lakh to 1.5 lakh for the additional HIPEC machine.
Yeah, you in your presentations also you explained in detail about the IPEC role of HIPEC and the benefit in GI onco, and also the drugs used in GI onco compared to ovarian cancers where you use different drug for HIPEC treatment.
Yeah.
And there is one more question from our resident: how robotic surgery more benefit compared to conventional surgery? Just our residents wants to know about it.
Yes, Baja. And not one size fits for everybody. But only thing is, with the help of robotic surgery, minimal incision, perioperative pain will be less. Sorry, post-operative pain will be less with a shorter incision. And the advantages for the surgeon is a better dexterity and a better visualization of the tissues. And with the help of the Firefly mode, we can use the ICG, which has already I have explained the benefits of ICG in esophagectomies, in the colorectal anastomosis, identification of the lymph nodes. These are the additional advantages with the help of the robotic or the laparoscopic surgeries.
Thank you, Dr. Ullas, for extensive discussion on GI onco surgery. So over to you, madam. Please introduce our next speaker.
Now inviting Dr. Vishwanath S., Professor and Senior Consultant and Academic Advisor, Medical Oncology, Apollo Hospitals, Bannerghatta Road, Bangalore, to begin with the second session. Welcome you, sir.
Yeah.
So Dr. Vishwanath sir is my teacher and academician, professor, and he is a lead of oncocysis in Karnataka region at Apollo Hospital, Bangalore. Sir, we warmly welcome you, sir.
Yeah. Thank you. I'm truly humbled by Dr. Lepakshi's invite as well as the introduction. He was a very good student, and I'm very happy to note that Dr. Lepakshi is doing exceedingly well in his practice. So, and I also thank AstraZeneca for this opportunity. So today's topic, after that wonderful talk by the previous speaker on the surgical management and GI cancers, shifting gears, let's talk about a new era in managing resectable gastric cancer with durvalumab plus FLOT. So this is the discussion outline. We'll first start with the overall gastric cancer burden and then move on to the current management of resectable gastric cancer. Why perioperative immuno-oncology, like Dr. Lepakshi said during his introduction, and then key randomized evidence, including the Matterhorn trial, the Keynote 585, the Attraction 5, as well as the Dante trials. And then you have the Matterhorn data in detail as well as the summary. So let's start with the gastric cancer burden. Gastric cancer is the seventh most common cancer and the sixth leading cause of cancer-related death. Stomach cancer is the second most common GI cancer among males and the third most common cancer site among females in India. So close to 75% of them are adenocarcinoma in CA stomach. Male to female ratio is 2:1. And the overall 5-year survival rate for gastric cancer in India remains poor, often less than 20%, primarily due to late stage of diagnosis and limited access to curative treatments. So if you see between males and females, in males, close to 20% of them are diagnosed at localized, and then around 50% of them are diagnosed at loco-regional stage, which is an important entity. And then we have around 25% being diagnosed those distant metastasis, and a small number because of the unknown extent. And very similar numbers in females as well, not much to differentiate between males and females. And this is the cumulative frequency of gastrointestinal cancer based on the 58 hospital-based cancer registries as per the National Cancer Control Program. And if you look at it, stomach in males comprises around 21%, and in females it is around 14.8%. So overall, if you see, it is around 18.5%. So let's move on to the management of resectable gastric cancer. If you look at stage-wise approach, in very early stages, it can be done by endoscopic or surgical resection. And we do know that stage 2 and stage 3, it is a resectable gastric, including stage 4A is a resectable gastric cancer. And that is where we adopt this perioperative chemotherapy plus surgery. And stage 4B is unresectable gastric cancer, where systemic therapy is the way to go. So NCCN guidelines also says that perioperative chemotherapy for resectable local regional gastric cancer, anything more than T2 node or node positive, and those who have got M0 disease, and postoperative chemoradiation if less than D2 dissection, and postoperative chemotherapy after primary D2 dissection. And the primary chemotherapy, perioperative chemotherapy is recommended for patients with resectable stage 1B or higher gastric cancer. Adjuvant chemotherapy is advised if surgery was performed without preoperative treatment. This was how we were managing. Now, many patients with gastric cancer experience disease recurrence after surgery. The proportion of patients with recurrence after surgery, if you look at it, it is significant. Around 61% of them do recur, and the proportion of patients experience recurrence within 2 years of surgery is close to 43%. So with surgery alone, there is a major unmet need, as 61% of the patients experience recurrence post-surgery and 43% of the patients report recurrence within 2 years of surgery. So we all know about this MAGIC trial. MAGIC trial established perioperative chemotherapy as the preferred treatment approach for resectable gastric cancer and gastroesophageal cancer. So rates of postoperative complications were similar between the treatment groups, 46% versus 45%. And if you see here, the PFS with the perioperative ECF versus surgery alone in resectable gastric cancer and gastroesophageal junction cancer, you can see that the PFS hazard ratio is 0.66, very good separation of curves. This goes to say that perioperative chemotherapy did benefit in these patients. And we also saw that these patients had an overall survival benefit with a 5-year overall survival benefit by around 13%, so 36% versus 23% numerically, and the overall survival hazard ratio of 0.75, which was also statistically significant. Good separation of the Kaplan-Meier curves again pointing out that perioperative chemotherapy improves outcomes versus surgery alone for patients with resectable gastric cancer and gastroesophageal junction cancer. Then came the FLOT4 study, which looked at ECF or ECX versus FLOT as perioperative therapy for patients with potentially treatable and resectable gastric adenocarcinoma or gastroesophageal junction adenocarcinoma. So this is a schema, histologically confirmed adenocarcinoma of the stomach or GE junction types 1 to 3 with a sufficient bone marrow reserve, good performance status of ECOG 0 to 2, and a normal liver function test with a good cardiac function and a good GFR, and good number of patients, 716 patients randomized as a 1:1 ratio to flot once in 2 weeks times 4 cycles. And in the other arm, it was ECF or ECX, which basically includes capecitabine instead of 5FU, once in 3 weeks for 3 cycles, and then followed by surgery. And then subsequently 4 more cycles of flot in the experimental arm, or in the standard arm, it was ECF or ECX, 3 more cycles every 3 weeks. And phase 2 basically looked at PCR, R0 resection, serious adverse effects of perioperative morbidity, and the 30-day mortality rate. And the phase 3 looked at primary endpoint was basically the overall survival in the intent to treatment arm. The secondary was DFS, R0 resection rates, as well as the adverse effects. So the perioperative flot significantly improved survival outcomes as compared to ECF or ECX in resectable GE junction, as well as the gastric cancer. So you can see that overall survival in the intent to treat population, good separation of the Kaplan-Meier curves, and you can see that 90% of the patients completed flot neoadjuvant, 60% of patients started flot adjuvant, and 46% of the patients completed flot adjuvant. So we do see this challenge even in our real world experience, where in the neoadjuvant setting we are able to complete in most of these patients, but in the adjuvant setting, because of the extent of gastric surgery and they become nutritionally deprived, they take time to improve. That is where is the challenge probably we have to improve, and there's a major unmet need here as well. But if you look at the median overall survival, as compared to ECF or ECX, there was almost 15-month additional survival, and the p-value was 0.012 and the hazard ratio was 0.77, indicating that there was a 23% reduction in the risk of death. And the median DFS, which is the disease-free survival, was also better by 12 months with a hazard ratio of 0.475, again statistically significant. And we do see in clinical practice that the pathological complete rates here and there, and it's around 16% as compared to only 6% with the ECF or ECX. And the hazard p-value was also significant. Talking about the adverse effects, if you see grade 1, grade 2 neuropathy were significant in the ECF as well as the perioperative flot. But what is important to note is that the grade 3 and grade 4 were still less than 10%. And neutropenia, yes, it is. We do give growth factors. So 51% of the patients did get neutropenic, and small amount of nausea, vomiting, and diarrhea. So overall, well tolerated. But of course, we'll have to individualize based on the patient's overall general condition as well as the performance status. So an analysis of tolerance and early survival outcomes with perioperative modified flot, where we reduce the doses of docetaxel as well as the this thing. So modified flot includes 2,400 milligram per meter square. We give it over 46 hours, and as opposed to 2,600 milligram per meter square on day 1 over 24 hours in the original flot for AIO study. What we do in our practice is also, reduce the docetaxel doses to a little, by maybe around to 75%, which also makes them well tolerate this particular regimen. So this was the survival data from the Tata Memorial study. So cohort 343 patient neoadjuvant, 87% completed neoadjuvant, 86% underwent curative resection. Neoadjuvant toxicity, grade 3, grade 4, diarrhea included 12%, febrile neutropenia 8%, toxic death, small number 2.6%. And in the adjuvant setting, 77% completed adjuvant treatment. This is very important to note as compared to 46% or 43% in the main trial of the flot. And toxicity is grade 3, grade 4, 12% diarrhea and febrile neutropenia and 6%, and 2-year survival of 69.4% with a median follow-up of 19 months. So modified flot is feasible with high completion rates and manageable toxicity and early survival outcomes, which was similar to results of the flot AIO study. So perioperative flot, perioperative modified flot versus EOX in locally advanced resectable gastric and gastroesophageal junction adenocarcinoma, results of a matched pair analysis. This was reported by our good friend Dr. Anant Ramaswamy from Tata Memorial Hospitals. Matched cohort of 593 patients, EOX 261, and modified flot of 332. So modified flot curative resection 86% versus 76% in the EOX, again was statistically significant, and the 3-year EFS was much better in the modified flot, 60% versus 39% in the EOX. And if you look at grade 3, grade 4 neoadjuvant toxicity, again, febrile neutropenia in 18% versus 2% in the EVO arm, and febrile neutropenia 8% versus 1.1% in the EVO arm. And adjuvant grade 3, grade 4 toxicity was also very similar to the neoadjuvant setting. So if you see the event-free survival, good separation of curves, we have seen that it was significantly better, 60% versus 39%, which was favoring the modified float arm. Let's move on to the prognosis of resectable gastric and gastroesophageal junction carcinoma. We know that it's poor with the current standard of care, and novel approaches are required. So the proportion of patients alive at 5 years with perioperative float is still only 45%, and the proportion of patients achieving PCR with perioperative float is only 16%. And we saw that it was a dismal 6% with the anthracycline based regimen. So based on this, there is a major unmet need to see if there's anything else which we can do to improve on the float approach. So this is where the concept of perioperative immuno-oncology drugs came into existence, and the PDL1 overexpression or upregulation is associated with the as a negative prognostic factor, including lymph node metastasis and tumor invasion. So what immunotherapy does, we all know, it primes the systemic immunity by exposing tumor antigens, clears minimal residual disease by activated T cells, builds the immune memory for long-term cancer control. And PDL1, as we know, is found in 40 to 60% of GE junction and gastric adenocarcinomas, supporting any kind of anti-PDL1 therapy. So these are the different trials investigating the addition of immune checkpoint inhibitors to chemotherapy in resectable gastric and gastroesophageal junction carcinoma. So we have the Keynote 585 trial, which looked at perioperative pembrolizumab with XP. XP stands for capecitabine and cisplatin, or 5FU plus cisplatin. And it was a phase 3 study, previously untreated gastric and gastroesophageal junction adenocarcinoma. Patients who were locally advanced, the primary endpoint was OS and EFS and PCR. The PCR benefit was there, but there was no EFS benefit, no OS benefit, and it was a negative trial. Then came the Matterhorn trial, which we're going to discuss in detail. This is a positive trial. There was a Dante trial, which looked at the other molecule, the atezolizumab perioperative plus float versus float alone. And again, there's a PCR benefit, but we are still awaiting the PFS data. And then there's the Attraction 5 trial, which looked at perioperative chemotherapy plus adjuvant nivolumab. And this looked at the relapse-free survival by the blinded independent central review, and it was a negative trial. So let's talk about the Attraction 5 trial. It was a phase 3 study of nivolumab plus chemotherapy as post-operative adjuvant treatment for stage 3 gastric cancer and gastroesophageal junction adenocarcinoma. So the study population includes stage 3 stage 3 of the gastroesophageal junction cancer who had undergone T2 dissection or more extended gastrectomy. The patients were randomized, double-blind, 755 patients, good number of patients, arm A, arm B, 377 and 378, not much to differentiate. And the patients underwent surgery, and post-surgery, the patients were given nivolumab, 360 milligrams once in 3 weeks for 1 year, plus S1 or Capox, which was decided by the investigator. And in the other arm, it was only chemotherapy, which was S1 or Capox. The primary endpoint was centrally assessed RFS, and the secondary endpoints included investigator assessed RFS, OS, 3-year RFS, as well as the overall survival rates. The Attraction study did not meet the primary endpoint of the RFS. The Keynote 585 trial, again, we discussed this. So basically, locally advanced adenocarcinoma of the GE junction or gastric cancer. In the neoadjuvant setting, it was the experimental arm included pembrolizumab plus cisplatin plus 5FU, or it was capecitabine plus cisplatin, and the patients received 3 cycles if it was 3 weekly, and then the patients also received 3 more cycles in the adjuvant, and then the patient continued pembrolizumab for completing 1 year. So in the other arm, it was only chemotherapy and there was no maintenance. It was only placebo. And this, if you see on the first interim analysis, there was some improvement of PFS, but subsequently the PFS did not translate into significant improvement in median EFS despite a marked numerical advantage. And there was no statistical improvement in the overall survival in the pembrolizumab plus chemotherapy group as compared to chemotherapy alone. So this brings us to the most important trial for today, which is the Matterhorn study, which is FDA approved for resectable gastric or gastroesophageal junction adenocarcinoma since November 2025. And AstraZeneca gets CDSCO approval for durvalumab and gastric cancer treatment. So we are able to use this in India as well. um, so it was, in fact, as we are talking about Matterhorn study at this year's American Society of Clinical Oncology, it was an absolute pleasure to listen to a talk by Dr. Elena Janjigan, who is the principal investigator for this trial, and also exchange some insights. So it really a fantastic trial. The study population was a phase 3 study, basically randomized, double-blind, placebo-controlled, multi-center global trial to evaluate the efficacy and safety of neoadjuvant and adjuvant durvalumab in combination with FLOT in patients with resectable gastric cancer or gastroesophageal junction cancer. So the study population included the locally advanced G junction or gastric cancer, no evidence of metastasis, good performance status, and the patient should be eligible for radical surgery. And there were subsequent stratification factors, which included Asia versus non-Asia, whether the patients had a lymph node positive disease or not, and PDL1 expression based on the TAP score less than 1% or 1% or more. So very good number of patients, close to 1,000, very well randomized equally. And patients in the experimental arm received durvalumab 1,500 milligrams once in 4 weeks plus FLOT. And in the other arm, it was the standard arm, which included FLOT. And durvalumab during the first 4 cycles of FLOT was only twice because it came 4 weekly. And after 4 cycles of FLOT plus 2 cycles of durvalumab, the patients underwent surgery. And 4 to 12 weeks later, there was an adjuvant cycle of durvalumab which started. And first 2 cycles, the patients completed 4 cycles of FLOT. And then the patients also underwent durvalumab initially with chemo 2 more cycles and then continued maintenance for 10 more cycles, basically to complete 1 year of treatment. I think not 1 year, it was probably 9 months because here you have 10. Yeah, no, it's 1 year of treatment, yes. So in the other arm, it was only the placebo. And of course, the patient did complete 4 cycles of FLOT as adjuvant. So the endpoints included EFS as a primary endpoint, and the secondary endpoint included overall survival, pathological complete response, safety, as well as the tolerability. So the participating disposition, 87% of patients with durvalumab plus FLOT arm completed surgery, which is very good to know. And the rates of treatment and surgery completion was similar between the arms. If you see patients who received any kind of neoadjuvant treatment in both the arms, it was similar. And completed durvalumab or placebo, 97% and 95%. Completed any FLOT, not much to differentiate. Attempted surgery, not much to differentiate. Completed surgery, 87% favoring the durvalumab arm versus 84% in the chemotherapy arm. The R0 resection in those who completed surgery, not much to differentiate. Received any kind of adjuvant treatment, numerically better in the durvalumab arm, and completed durvalumab or placebo, not much to differentiate. So overall, if you see, the arms are well matched numerically. In few situations, durvalumab arm fared better. So if you look at the baseline demographics, the median age was around 62, 63 years. And also good to know that close to 20% of the patients were Asians, and most of them had a good performance status. And the gastric cancer comprised around 2/3 and G junction around 1/3. And if you see, non-T4 disease was 75% and T4 was 25%. Node positive in close to 70% of the patients, and PDL1 positivity by TAP score of 1% or more in 90% of the patients. And a small number of patients had MSI high. And also important to note that 27% of the patients actually had a diffuse or probably the signet ring kind of histology. So this is a very nice curve in any solid oncology to see that early separation of curves. And you can see that durvalumab plus FLOT, the median event-free survival at 24 months was 67.4%, favoring the durvalumab plus chemo arm as compared to 58.5% in the FLOT arm. And the median EFS was 32.8 months. And there was a 29% reduction in the risk of recurrence or progression or death. and the hazard ratio of 0.71. So event-free survival in key subgroups, again, the forest plot, again, if you see in most of the situations, it's all favoring the durvalumab group, except probably the diffuse histology. It's difficult to say, it's coming close to the midline, but otherwise, whether the patient was, in fact, males fared better than females, irrespective of the age, less than 65 or more than 65, they fared well. Non-Asians fared little better. Node positive disease, in fact, did better. That is good. And as expected, the patients who had a PDL1 of more than 1% by TAP score was fared better, and not much to differentiate whether you. In fact, G junction carcinomas did better than as compared to gastric. And like we said, intestinal variant did better. So the final overall survival was also reported, and durvalumab plus FLOT demonstrated a statistically significant and clinically meaningful improvement in overall survival as compared to placebo plus FLOT in the intent to treat population. Again, if you see that at 36 months, the delta was 6.7% and indicates that the hazard ratio was 0.78 with a p-value of 0.021, and the median duration of follow-up was quite good. So this indicates that over a period of time, also in a very bad malignancy like stomach, we are able to demonstrate this kind of delta by the addition of immunotherapy. So again, the forest plot for the various subsets, very similar to what we discussed. Patients with diffuse did not do that well, and the G junction did better, and the PDL1 positivity patients did better, very similar to what we saw with the event-free survival. So those who had a TAP score of 1 or more, their hazard ratio was 0.79 for the overall survival and 0.79 for TAP score less than 1. So that indicates that PDL1 is not very important, and we do start irrespective of the PDL1. So the pathological complete response rates of durvalumab plus FLOT achieved a statistically significant increase in PCR as compared to FLOT alone. We saw that it was 16% with only FLOT. Here it is 19%. We are increasing it by 3 more percent. I'm doing a cross trial comparison in that. And here it is 7% with FLOT alone. There it was 6%. So we are seeing around 3%, 3 to 4% additional benefit of PCR by giving durvalumab. But may not be a very fair comparison. It's because it's a cross-trial comparison. But if you see here, in this particular study, there's a significant almost 12% benefit in the PATS-CR. Safety profile, we have discussed this, but what is important to note is the grade 3, grade 4. Neutropenia, yes, there was not much to differentiate in the two arms. If you see, that's the most important thing. And we are not able to differentiate as far as durvalumab is not contributing significantly to any additional side effects. So the key takeaway, addition of durvalumab to FLOT improved the overall as well as the event-free survival in resectable gastric and gastroesophageal junction adenocarcinoma. And to summarize, gastric cancer is the fifth most frequent advanced diagnosed cancer and the fifth leading cause of cancer-related death worldwide. FLOT4 established perioperative chemotherapy as the standard. Relapse rates remained a major challenge, and that's how immunotherapy came into existence. And we've looked at various trials, including the Dante trial, where the PFS data is awaited, Keynote 585, which is a negative trial, Attraction 5, again, not much of this thing. So overall, we are left with only the Matterhorn, where there's an improvement in the EFS as well as the overall survival. And across various subgroups also we have seen that there is a benefit and no new safety concerns as compared to FLOT, and the profile is aligned with known durvalumab and FLOT toxicities, no significant delay or decrease in number of surgeries seen. And this proves that Matterhorn study establishes perioperative durvalumab in combination with FLOT as the new standard of care in stage 2, stage 4A, resectable gastric and gastroesophageal junction adenocarcinoma. And the 3 Fs of Matterhorn, finite treatment, so it's not indefinite, and it's flexi-FLOT, and the first IO with meaningful EFS as well as the overall survival benefit. So this is quite good an acronym. And would like to congratulate AstraZeneca for this wonderful molecule which we are using in combination with chemotherapy. Thank you so much for a patient listening, and I would like to thank Dr. Lepakshi again for this opportunity.
Thank you so much, sir, for the wonderful session. Over to Dr. Lipakshi for the Q&A session again.
Thank you, sir. Thank you. As usual, excellent presentation, sir. We always to learn from you, sir. And
Thank
there
you.
are some few chat box, sir. Even there, they also expressed thank you, and you are the best speaker and excellent present. Just wanted to know any molecular tests like NGS or PD-L1 is must in non-metastatic G junction bar gastric adenocarcinoma.
Yeah. So, Dr. Lepakshi, that's a wonderful question. And we have seen in the Matterhorn trial data itself that patients with a TAP score of 1% or more fared better. But when we saw the overall survival, there's not much difference between less than 1 versus more than 1. And I'm sure, Dr. Lipakshi, you would agree that even in our clinical practice, we are not giving too much importance to PDL1.
No.
That was actually your opening statement as well. That irrespective of PDL1, we are going ahead and giving durvalumab. And especially in the neoadjuvant setting, we don't have anything else to do. So we are seeing that the paths here, even if you're able to get some additional paths here, we do know that from breast cancer and various other malignancies, including stomach, that it is a good surrogate for overall survival and event-free survival. So I think based on that, I would not give too much importance to PDL1. In fact, I don't assess in the neoadjuvant setting at all.
Agreed, sir. Agreed. Sir, again, one more, sir. One more question. Like 1 year of immunotherapy, that is durvalumab plus FLAG, can it be increased to 2 years, especially in high risk group like non-PCR or nodal burden is high? Is there any? Because even though Metanon trial also concluded for 1 year durvalumab therapy, is there any thing in especially high risk group can be continued for another 1 year also? Is the one more question, sir.
Yeah, that's an excellent question again, but that is more of a question to AstraZeneca as well as the principal investigator, Dr. Yelena, who should be able to answer this question whether patients who have not attained a PCR should receive 2 years of durvalumab. We may see something like that coming up because we do know that patients who receive 2 years of immunotherapy in that kind of a high risk situation do much better, and maybe over a period of time this would be a very interesting trial.
Thank you very much, sir. As usual, you are excellent, sir. Thank you so much.
Thank you so much, Dr. Lepakshi. Thank you, AstraZeneca, and thank you, Horizon Group.
Over to Origin team. Please introduce and welcome our speaker.
Inviting our next speaker, Dr. Sandeep KS, medical oncologist, Raichur, to begin with the next session. Over to you, Dr. Sandeep. Thank you.
Oh, thank you for the introduction. First of all, I thank Dr. Lepak sir and his team, as well as I extend my thanks to the Zydus for giving me this opportunity to present today's session. Okay, so, shall I share my PPT?
Yes, sir, you can share.
I'm unable to share this. Wait.
Yeah, welcome, Dr. Sandeep. Thank you. Thank you so much for joining. And as usual, for my meetings, you always supportive. Thank you. Welcome again.
Thank you, sir. Thanks for emailing. Can you see my slides, sir? Hello?
No. I think, Manya, can you share the slides?
Yes, sir, I'll team will share.
Yeah.
Okay, shall I begin? Hello?
Yes, sir.
Yes, sir.
Please, Dr. Sandeep.
Okay. Good evening, everyone. So today I'm going to discuss regarding the nivolumab, its impact and role in GI cancers. So going to next slides. this is the Tista, the biosimilar, which is mainly produced by Zydus, which has made a tremendous improvement in mainly affordability of the patients for this nivolumab immunotherapy, which is very much affordable. So going to the next slides. See this the Tista by the Zydus. It's also a biosimilar to this our original nivolumab, which is almost contain the same active drug substance like the innovator, which is also a this IgG4 kappa monoclonal antibody, which is also similar like approximately similar like innovator in case of this molecular weight, and it's up around 143 kilodalton, and also expresses genetically engineered aldehyde cells group in this monoclonal antibody to a innovator, and the developed with the same pharmaceutical combination as that of the our original nivolumab. Next slide. So this actually approved in the strength of 40 mg, which comes in 400 ml vial, and also 100 mg, which is comes in 10 ml vial, and it's even like a intravenous like a innovator. Next slide. So the nivolumab indications in G junction and esophageal cancers, in a mainly gastric cancer, gastroesophageal junction, and also esophageal adenocarcinomas. In these adenocarcinomas, nivolumab usually approved in combination with fluoropyrimidine and platinum-containing chemotherapies, which is indicated for treatment of patients with mainly advanced or metastatic gastric cancer in a first line G junction as well as esophageal adenocarcinomas. Next. It's also approved in advanced settings. In case of G junction adenocarcinomas, if patients in a neoadjuvant setting, if they received chemoradiation followed by surgery, if patient doesn't have any pathological complete response, then the nivolumab is approved in advanced settings. We'll discuss about these in further slides. Next slide. Next slide. So coming to our first trial, Checkmate 649. See, this is advanced adenocarcinoma of G junction gastric cancer. Before these immunotherapies, with the chemotherapy, was the PFS and OS was very much detrimental. Now with this introduction of these immunotherapies, there is a quite improvement in the OS and PFS benefits. So Checkmate 649, which mainly esophageal gastric and esophageal junction adenocarcinomas first line, which is used in a first line, which is a randomized phase 3 trial with a median follow-up of 36.2 months. In this, they randomized it into PDL1 status based on more than 1%, less than 1%, Asian and US versus Canadian versus rest of the world, and also based on performance status 0 versus 1, and also the chemotherapy backbone, whether it's a Xelox or the FOLFOX. So these patients were mainly previously untreated. They were the fresh metastatic patients, and they are mainly inoperable recurrence or advanced stages of carcinomas, where HER2 should be negative, and ECOG with the performance of 0 to 1. A total of 2031 patients were randomized. The randomized arms were between the nivolumab chemotherapy, just chemotherapy, or IO combination, that is nivolumab and ipilimumab chemotherapy combination. The chemotherapy used were either 3-weekly Xelox, with that the 3-weekly nivolumab, the dose of 360 mg was used, or 2-weekly FOLFOX with the nivolumab 2-weekly dose of 240 mg flat dose were used, which is also compared to the just chemotherapy without chemotherapy. And also third arm was nivolumab and ipilimumab every 3 weekly into 4 cycle, followed by just nivolumab every 2 weekly until disease progression, which was used. And OS and PFS are mainly analyzed for CPS score of more than 5. Next. So OS PFS duration of response based mainly for CPS score of more than 5. In patients with CPS score of more than 5, if you see the overall survival, it is 14.4 months versus 11.1 months. when the immunotherapy is added to the chemotherapy, the median OS was improved almost 3 months with a hazard ratio of 0.70. If you see the curve, there's a very well separation between these two curves in OS where CPS is more than 5. In case of PFS, it is 8.3 versus 6.1. When the immunotherapy is added to the chemotherapy, it is 2 months of additional PFS benefit with a hazard ratio of 0.70. And also duration of response. Duration of response also improved between these groups, between the immunotherapy added to the chemotherapy versus chemotherapy. It is 9.6 versus 7 months. So with the addition of this immunotherapy to the chemotherapy, mainly in case of CPS score of are equal to or more than 5, there is a significant improvement in the PFS, OS, as well as the duration of response. Next slide. In case of any population, irrespective of PWS status, intention to treat population, if you see, there also there is a significant improvement in the addition of new immunotherapy to the chemotherapy. If you see the OS, it is 13.7 versus 11.6 months, almost 2 months improvement in the OS with hazard ratio 0.79. That is almost 21% improvement if you add nivolumab to this chemotherapy arm. Or PFS benefit of 7.7 versus 6.9 with a hazard ratio 0.79. And even duration of response also improved from 6.9 to 8.5 months if we add immunotherapy to this chemotherapy. So even in whatever the PD-L1 status, the adding nivolumab to this chemotherapy arm is benefiting to the patients. Next slide. So if you see in the patients with adenocarcinoma G junction or esophageal adenocarcinoma, or these case where PD-L1 CPS is more than 1, the median OS benefited significantly. That is from 11.1 months to 14.4 months if you add nivolumab to this chemotherapy arm with a hazard ratio of 0.70. That means almost 30% of patients are benefiting with this nivolumab, 30% additional benefit. And if you see PFS, it is improved from 6.1 to 8.3. Almost it is the addition of 30% and 2 months improvement in PFS if you add nivolumab to the chemotherapy arm in case of CPS more than 5. In case of all the randomized patients, irrespective of PD-L1 status, if you see, there is a median OS of 13.7 versus 11.6. And there is a median PFS of 7.7 versus 6.9 with hazard ratio almost both are 0.79%. So this much of significant improvement of PFS and OS as well as durable responses also added with this addition of nivolumab to this chemotherapy arm. Next slide. So OS data at 5 years follow-up with the new and chemotherapy versus chemotherapies. I already presented this one. And also OS for overall population 12 months versus 6 months, which is shown in these trials. And the OS in PD-L1 CPS more than 6, it is 16 months versus 6 months. Such a significant improvement if your CPS is more than 5. Even if CPS is more than 1 also, there is significant improvement of this OS and PFS benefit. Next slide. So nivolumab shown a superior OS, PFS benefit and the acceptable safety profile when the nivolumab is combined with these chemotherapies versus if you give chemotherapy alone in a untreated patients with the advanced gastroesophageal junction esophageal adenocarcinoma in the first line mainly. So next slide. So we discussed about the first line setting in adenocarcinoma. Now we are discussing about adjuvant settings. See checkmate 577, which is used this nivolumab in adjuvant setting. If you see, this is a randomized double-blind phase 3 study where stratified by squamous versus adenohistology with the lymph node status of anything more than 5 N1 or N0, and it is stratified between PD-L1 more than 1% versus less than 1%. Patients are mainly stage 2 and 3 esophageal carcinomas, gastroesophageal junction adenocarcinomas or squamous with residual pathological reference after CRT plus surgical resection. This is mainly extension of this cross trial. We have seen in the cross trial that in case of esophageal or esophageal adeno esophageal gastric junction tumors, If they are fit patient, we can use a tri modality using chemo with radiation, chemo RT, followed by surgery. And after the surgery, if patient has a residual disease, if they don't achieve this pathological complete response, then those patients has been used this nivolumab 240 mg, that is a flat dose 2 weekly for almost 16 weeks. Then 480 mg for 4 weekly, which is used up to 1 year. If we use this nivolumab versus observation, the DFS and OS benefit will tell in next slide. Next slide. So if you see the median DFS, it is doubled. If you don't give any additional therapy in case of patient doesn't achieve pathological complete response, it is 11 months. If you give nivolumab in adjuvant setting for 1 year, the benefit is 22.4 months. So it is almost median DFS is doubled if you use adjuvant nivolumab. And the overall survival, if you see, that is 30.5.3 months versus 51.7 months. That is with addition of almost 20 months improvement in the median OS. So such a significant DFS and OS benefit is there when you use this nivolumab in adjuvant setting. Next slide. So with the nivolumab, we're reducing 30% of reduction in the risk of recurrence with the doubled median DFS. So DFS and DMFS benefits with mainly DMFS is distance METs disease-free survival. With adjuvant nivolumab were maintained at a minimum of 5 years follow-up compared to the observation. And also 5-year OS rates were higher with nivolumab, that is 46 versus 41%. So such a significant improvement if you use nivolumab in an adjuvant setting. So next slide. And the overall survival, which is median OS of almost 51.3 months compared to the 35.3 months, almost 16.4 months longer if you use these nivolumab in adjuvant settings compared to the observation after the chemo, radiation, and surgery. So next slide. So in conclusion, mainly in patients with esophagus or esophagogastric cancer who had received neoadjuvant chemoradiotherapy and surgery, disease-free survival was significantly longer among those who received nivolumab adjuvant therapy among the patients who were compared to the placebo, mainly in case of patients had a residual disease. So addition of this nivolumab giving us a very good survival results. Okay, next slide. So with this, the broadest clinical coverage, only when the immunotherapy is spanning the full disease continuum, that is first line advanced metastatic gastric gastroesophageal junction and gastric adenocarcinomas, immunotherapy with chemotherapies, and also in adjuvant setting where post neoadjuvant CRT is used with after surgery in the residual disease, the adjuvant immunotherapy, mainly nivolumab, giving us the benefit. And other immunotherapies are more indicative or biomarker segmented, mainly HER2, PD-L1 enriched or PERIAP only. Those things are there. Next slide. So strongest evidence of chemotherapy with immunotherapy backbone. That is, we have discussed this checkmate 649. When compared to the chemotherapy alone, the patients with CPS more than 5 or CPS more than or equal to 1, they have benefited with this immunotherapy. In CPS more than 5, there is a consistent and significant improvement in the OS and PFS benefit when you add this nivolumab to these chemotherapy backbone, mainly platinum and fluoropyridine chemotherapy backbone, and less biomarker dependency. That is, even in case of HER2 positive disease, we can use this pembrolizumab along with this HER2 targeted trastuzumab. That is also giving us significant additional benefit irrespective of PD-L1 status. Adding pembrolizumab to this HER2 targeted therapy is improving the DFS. And the high PD-L1 enrichment, rational 305, that is tislelizumab with the chemotherapy, if used in a high PD-L1 status, there is a good significant PFS and OS benefit. Next. So only with immunotherapy, if you add only adjuvant immunotherapy, there without any chemotherapy, if you add just adjuvant immunotherapy, there is a almost doubling of this DFS benefit and also significant OS benefit after neoadjuvant CRT and after surgery if the patient has a residual disease. So a single immunotherapy giving us a significant benefit in case of this adjuvant setting. Next slide. So nivolumab, which is more versatile and at least restrictive immunotherapy in least restrictive immunotherapy, which can be used even at PDL1 or 1 status are equal to PDL1 status. We can use this nivolumab in both in advanced gastric gastroesophageal junction cancer or in case of an adjuvant setting. It is giving a significant benefit. So next slide. So till now we discussed regarding the adenocarcinomas, mainly in advanced as well as adjuvant setting. Now we are going towards this squamous cell carcinoma of esophagus. In case of nivolumab in esophageal squamous cell carcinomas, which is mainly indicated in combination with the platinum and fluoropyridine chemotherapy backbone in a first-line setting, where unresectable or advanced metastatic esophageal carcinomas. In the nivolumab in combination with ipilimumab without chemotherapy, nivolumab ipilimumab combination, mainly in case of PD-L1 more than 1% for unresectable advanced esophageal squamous cell carcinomas. These are the two setups, and nivolumab is indicated in the treatment of advanced recurrent metastatic esophageal squamous cell carcinoma after prior fluoropyridine or platinum chemotherapy setting. So nivolumab in addition to the chemotherapy arm in an advanced setting, nivolumab in addition to the ipilimumab combination in a PD-L1 more than 1% setting, or nivolumab in a second line or third line setting with the prior chemotherapy. Patient received already prior chemotherapy, progressed on prior chemotherapy. So these are the three settings we are using nivolumab in a esophageal squamous cell carcinoma. So next slide. So checkmate 648, which is a international randomized phase 3 trial, which they used even in advanced recurrent squamous cell carcinomas. No prior systemic therapy for advanced disease, measurable disease, where the nivolumab given in the backbone of chemotherapy backbone of fluoropyridine and cisplatin, fluoroaerosol cisplatin, which is the nivolumab given every 2 weekly and the chemo is given 4th weekly. Fluoropyridine and cisplatin, and the nivolumab with the ipilimumab, nivolumab 3 mg kg 2 weekly, ipilimumab 1 mg kg 6 weekly, and the CT chemotherapy alone were compared. So these three are also compared in mainly unresectable advanced esophageal squamous cell carcinomas who are not received any prior systemic therapies. Next slide. So according to this phase 3 trial, they have analyzed this OS-PFS in patients who are having PD-L1 status of more than or equal to 1% CPS score mainly. So overall survival, if you see, or in an overall population, if you see, the median OS is 12.8 versus 10.7 months. So even at the PD-L1 just more than 1% or equal to 1%, the OS is benefited, and the HR is rate of 0.78. And in case of PFS, if you see median PFS improved almost just 5.6 versus 5.8 months when you add this to this chemotherapies. Next. So overall OS at 2 years 29 versus 19%, and the median OS of 12.8 months versus 10.7 months in nivolumab added to the chemotherapy versus if you give chemotherapy alone in a metastatic or advanced setting. Next. So if you see PD-L1 more than 1% population, that was previously what we discussed is just overall population irrespective of PD-L1 status. Now if you see PD-L1 more than or equal to 1%, the median OS is improved from 9.1 to 15 months. HR ratio only 0.59. That is almost 41% of additional benefit if you give immunotherapy to this chemotherapy backbone in a OS. In PFS, if you see, it's improved from 4.4 months versus 6.8 months with HR of 0.7%. If you use this immunotherapy to chemotherapy, if you see in OS, even the curves are separating at the earliest, and there is a significant difference between these two curves. Even in PFS also, there is a significant difference between these two curves. So in case of patients with PD-L1 more than or equal to 1%, the 2-year OS rate were almost so much difference between the OS rate, that is 31 versus 12% with the nivolumab adding to the chemotherapy versus chemo arms, and the median OS is 15 compared to the 9.1 month. Next slide. So OS and PFS at 5 year. Median OS we already discussed. If you use mainly nivolumab in more than PD-L1 more than 1%, if you use nivolumab with the chemotherapy, it's 15 versus 13.1 versus 9.1. That is the first benefit is with the nivolumab added to the chemotherapy. Next best is when you use nivolumab ipilimumab combination followed by nivolumab maintenance. So that is the second highest benefit with 13 months of OS. The last one is when you use chemotherapy alone. And HR also almost similar between this immunotherapy with chemo and immuno combination. And the 60-month OS was 12, 18, and 7 months. And median PFS, mainly median PFS 6.8, 4, and 4.4. So adding nivolumab to the chemotherapy arm significantly improved the PFS and OS both. With HR ratio also significantly better with this nivo with chemotherapy combination. Next slide. So the nivo with chemo and nivo with ipi demonstrate long-term survival benefit compared to the, and also durable response compared to the chemotherapy after 5 years of follow-up. Next slide. So with this trial, we come to know that nivolumab plus chemotherapy and nivolumab plus ipilimumab continue to demonstrate the clinically meaningful OS benefit, PFS as well as durable responses compared to the chemotherapy alone, with not much significant safety concern. There are very manageable safety signal concerns, and also we now have a good long-term follow-up with these checkmate trials, and the further supporting the use of first-line treatment of this immunotherapy in advanced esophageal squamous cell carcinoma. So both in adenoid squamous, this addition of this nivolumab to the chemotherapy has significantly improved the OS and DFS benefit. Next trial is the Attraction 3 trial. This trial is mainly for second line or subsequent line, when you already used first line some chemotherapies to this advanced esophageal squamous cell carcinoma in a recurrent setting. So this is given irrespective of PD-L1 status. So here the immunotherapy is given alone, not combined with any chemotherapy. It's given alone, which is compared with the chemotherapy arms. The immunotherapy given is that nivolumab 240 mg flat dose was given every 2 weekly until disease progression, compared to the mainly chemotherapy, which is paclitaxel taxanes. So next slide. So with this single agent immunotherapy compared to the chemotherapy in a second and subsequent line, if you see this response, the median OS improved from 8.5 months to 10.9 months, which is a p-value is very much significant with the HR ratio of 0.79, and the curves also, if you see, they have started separating from early in the course, and also the duration response also significantly better compared to the chemotherapy arm. This is the Attraction 3 trial. So next slide. So median OS improved from 10.9 to 8.4 with a very much significant p-value in when you use nivolumab alone compared to the chemotherapy. At 36-month follow-up, the OS is 15-month was 8.7 when you use nivolumab compared to the chemotherapies. And the first randomized trial to show OS benefit in a previously treated esophageal squamous cell carcinoma. As I told that, this is in second or subsequent line when you already used previously chemotherapy in a esophageal squamous cell carcinoma. So in conclusion, we have seen that with the checkmate trials, this nivolumab used in both second line therapy demonstrate clinically meaningful long-term improved in OS compared with the chemotherapy alone in a previously treated patient with advanced esophageal squamous cell carcinoma. And the OS was consistently improved in nivolumab group compared with the chemotherapy group, regardless of this data. And the nivolumab was tolerated very well over 3 years for data. Next slide. So in esophageal squamous cell carcinoma, only immunotherapy with tacrolimus therapy, that is nivolumab, which is PD-L1 inhibitor with robust evidence in both first line, checkmate 648, and in second line, Attraction 3, which we discussed, has shown a significant DFS and OS benefit. And the proven survival benefit irrespective of PD-L1 status, Attraction 3 doesn't, irrespective of the PD-L1 status in Attraction 3, the single agent nivolumab compared to the chemotherapy is improved OS and DFS significantly. And flexible first line backbone, dual IO, or you can use IO with the chemotherapy. In treatment for 648, we have seen that you can use immunotherapy with the chemotherapy, or you can use immunoimmun to avoid chemotherapy if a patient is not fit for chemotherapy. So both the combinations shown better results compared to the chemotherapy alone. So even if it can be a flexible first line backbone when you use nivolumab in a esophageal squamous cell carcinoma. In a second line, we have discussed that attraction 3, which is a global reference with second line IO in a esophageal squamous cell carcinoma, which is single agent chemotherapy has shown a significant benefit over a chemotherapy. And the consistent OS and hazard ratios across the population, we have discussed these all trials. Hazard ratio of almost every trials was showing 0.74 in the intention to treat. If the CPS is more than 5 or more than 10, the HR is significantly improved. So nivolumab is the most versatile. That means you can use a single agent, or you can combine with chemotherapy, or you can combine with other immunotherapy, which can be used in esophageal squamous cell carcinoma and effective across all the lines, even in the first
Sorry
line.
for the interruption, sir.
Hello, ma'am.
Sir, sir, sorry for the interruption. Kindly conclude the session in next 5 minutes.
Okay, next slide, please. So in this, I'm going to end my session. So this is the biosimilar nivolumab, which is nivolumab wherever in GA cancer we use extensively. So this biosimilar has made us it's economically feasible to many of our populations. So thank you for everyone for listening peacefully and patiently. Thank you.
Thank you so much, sir, for the session. Now welcoming Dr. Abhilash GH, Consultant Medical Oncologist and Hemato Oncologist, BHIO Mysore, for the next session. Kindly over to you, sir.
Thank you, Dr. Sandeep, and welcome, Dr. Abhilash, for the next session.
Sir, are my slides visible?
Not yet. Yeah, now it's okay.
Yeah, thank you, sir. I want to thank Dr. Lepakshi, sir, for the opportunity. I think slides are visible, so I think I'll start. Today, I think I will be talking about the role of tislelizumab. Now, I think we have many Indian generic options available for the treatment of esophageal squamous cell carcinoma. So I'll be discussing about rational 306 trial, that is tislelizumab with chemotherapy versus placebo on chemotherapy for advanced or metastatic esophageal squamous cell carcinoma in the first line. So rational 306 is a global trial. About 649 patients were randomized from 162 sites of 16 countries. I think Asia, Europe, Oceania, North America were the geographic regions which were involved. And I think 75% of the patients are from the Asian origin, and the rest of the world contributing about 25% of the patients' population. So, coming to the study design, it is a global randomized, double-blind, parallel arm, placebo-controlled phase 3 study. For key eligibility criteria was patients who had unresectable, locally advanced, or metastatic esophageal squamous cell carcinoma. Those who had not received any prior systemic therapy for the advanced disease, and with a good ECOG performance status of 0 or 1, and with a measurable or evaluable disease as per RESIST version 1.1. They were randomized, 1:1 randomization was done to receive either tislelizumab 200 mg every 3 weekly once with the investigator chosen chemotherapy. The investigator chosen chemotherapy was there were two options, either to use a platinum with a 5FU based regimen, and also they had an option of platinum with paclitaxel, which was compared with placebo and investigator based choice chemotherapy. And the primary endpoint was to know the overall survival in all the randomized patients, the intent to treat population. And secondary endpoints were to see progression free survival, objective response rate, and duration of response. and also OS in the PDL1 score more than 10% subgroup, and health-related quality of life index and safety. And baseline PDL status, I think TAP score of more than 10% was in about 37.7%, and less than 10% was seen in about 50% of the patients. So I think nowadays we have various scoring methods for PDL1. So I think various hospitals use different PDL1 scoring methods. So the TAP and the CPS are the most one which have concordance. So where they evaluate both tumor cells and immune cells. And moreover, TAP is less time consuming since there is no need to differentiate immune cells and conduct cell counting. And sometimes in case of mucosal biopsy, there might be some discordance because of less immune cells. I think both they use Ventana as the TAP scoring and DACO in the CPS scoring. And scoring method is in CPS we use cell count, and it is a bit of time consuming, whereas in TAP scoring, I think visually they estimate the percentage of tumor area with PDL1 expression. Taking the baseline demographics and disease characteristics in both the arms, and the median age was about 60 to 65 years. And as I said, most commonly male were the most common population, and most of the patients are from the Asian origin and with a good performance status. And most of them are squamous cell, as early as that study only indicates. And prior definitive therapy and surgery was done in about 30%, and radiation was done in about 12 to 13%. And PDL was more than 10% in 37.7 versus 35%, and less than 10% in about 50 to 55% of the patients. And median duration of treatment is 6.4 months in the Tisla arm versus 4.9 months. And chemotherapy, I think it was most of them received 5FU and platinum in about 45%, and rest of the patient received either paclitaxel with a platinum compound. So coming to the overall survival in intent to treat population, we can see the median overall survival is about 17.2 months in the Tisla arm versus 10.6 months in the placebo arm, with a very good hazard ratio of about 0.66 and a p-value of less than 0.001. And there is almost 34% reduction in the risk of death, and about 6.6 months of additional overall survival benefit was seen when they used islalizumab with chemotherapy. So the primary endpoint was met with a statistically significant and clinically meaningful improvement in the overall survival. So when we look at the PDL1 status, so on the left side we have PDL1 more than 10%, and there also patient had a median OS of about 16.6 months versus 10 months, with a hazard ratio of 0.62. And those patients who had PDL1 score less than 10% also, they had benefited with the Tisley. About the median OS is about 16.7 months versus 10.4 months, with hazard ratio of 0.72. So the worst benefit was seen with Tisley plus chemo was observed regardless of the PDL1 expression status. So we had so many pre-specified subgroups like age, sex, smoking status, ECOG performance status, and also the geographical region analysis, race, or a disease status, and previous treatment received. I think the forest plot shows there is clear benefit which favor tislelizumab with chemotherapy across all the pre-specified subgroups. So coming to the PFS and overall response rate, I think I am not able to. PFS also, I think the 2 year, 1 year PFS rate is about 30% in the Tislam versus 15% in the chemotherapy. The PFS rate is almost double, and the median PFS is about 7.2 months. And the response rates also we can see on the right side. There is overall objective response rate was about 63.5% versus 42.4%, and there's a difference of in the response rates about 21%, so showing clear benefit with tislelizumab. So I think most of the immunotherapy, I think we are well versed with using the immunotherapy, but most of the side effects are, expected. Like most of them had anemia, neutropenias, and sometimes leukopenias, and no major safety signals were seen. And immune related adverse effects also more than grade 3, and more than grade 3 was about 8.6%, and most of them, both arms have done similar in with regards to toxicity. So we have so many options now in the first line treatment of esophageal squamous cell carcinoma. I think we started with using nivolumab and pembrolizumab. We had results with Keynote 590 and Checkmate 648. I think when we compare the 306, I think the median OSF is 17 months with tislelizumab, and it is about 12 months and 13 months in the Nivon pembrolizumab. And even the median PFS is about 7.3 months with tislelizumab, and response rates are also higher, and duration of response is about 7 months. And those patients who had PDL1 positive, there also the response was better when we used tislelizumab. So median OS and PFS benefit was clearly better when we compared with nivolumab and pembrolizumab. Maybe patient population is different, but it's a cross trial comparison. So in the second line, when we have a trial rationale 302, when we use tislelizumab with chemotherapy for advanced or metastatic esophageal squamous cell carcinoma in the second line. So patients who had metastatic ESCC, those who have progressed during or after the first line of systemic treatment with a good PS of 0 or 1, about 512 patients were enrolled for randomized 1:1 randomization was done, either to receive tislelizumab monotherapy as 200 mg 3 weekly medicine, and compared with chemotherapy either with paclitaxel 3 weekly or a weekly regimen, or docetaxel and irinotecan as day 1 and day 8 regimen. I think majority of the patients received irinotecan, and treatment was continued until disease progression. And primary endpoint was again overall survival in all randomized patients. And the key secondary endpoint was to know overall survival benefit with TAP score who was having more than 10%, and other secondary endpoints like PFS, duration of response, health related quality of life, and safety. So again, baseline characteristics, I think most of the baseline characteristics well matched with tislelizumab and chemotherapy. Both the arms had 256 patients, and TAP score was more than 10% in about 35% versus 27%, and other most everybody were metastatic at presentation. So seeing the OS for overall patients and also patients who had TAP score more than 10%. So those patients overall, all comers, there is 30% reduction in the risk of death when we compare it with chemotherapy, and there is 2.3 months additional OS benefit was seen. The median OS is about 8.6 months versus 6.3 months with a significant p-value, and those with the TAP or visual CPS score more than 10%, they have responded better, about 46% in reduction in the risk of death, and about 3.5 months of additional OS benefit was seen. And even in the second, and also tislelizumab has shown a clear benefit when we use as a monotherapy option. So again, all the pre-specified subgroups comparing both the treatment arms as compared to age, the TAP scoring, region, race, sex, and chemotherapy. So all what tislelizumab has done better in all the pre-specified subgroups. So come to PFS and ORR and duration of response. So when we see this Kaplan-Meier curves, so the PFS benefit, the curves are started to separate 3 months after the randomization and showing benefit with tislelizumab. And again, the overall response rates about 20% versus 9.8%. Again, it is almost 2 times more. And duration of response also is better. That is 7.1 months compared to 4 months. So those patients who respond, I think, as we can see that the long tail, they had to durable tumor response when compared to chemotherapy alone. So again, I think the treatment emergent adverse effects and treatment related adverse events, the tislelizumab arm, they have not shown any significant new safety signals, and they have clearly have a tolerable safety profile when we compared with chemotherapy, and the lesser rates of grade 3 and above role, and also lower rates of treatment discontinuation. So these are the most commonly seen, I think, except for the autoimmune side effects. I think all the others like myelotoxicity and the GI toxicity and all those things, I think they're more commonly seen in the chemotherapy arm, and there are no new safety signals concerned with the tislelizumab. So they also did health-related quality of life assessment and the change of baseline scores. Two types of scores they used to assess at week 12 and week 18. So patients' general health and the physical functioning, fatigue, and the patient's symptoms of dysphagia and the reflex and all those things. I think they were improved with the tislelizumab arm, and patients' quality of life scoring, and also they were statistically significant when compared with only chemotherapy. So this is a overall survival comparison across studies. The OS reported in the first line and second line. So it said rational as a highest overall response, overall survival like 17.2 months, whereas Keynote had 10.7 and Checkmate 648 at 13.2 months. But when we use it in the second line, so even except for the attraction 3, I think rational has 8.6 months of median overall survival benefit, and PFS again 7.3 with the tislelizumab versus 5.6 and 5.8 with Nivo and Pembro, and PFS in the second line, I think PFS is not so significantly seen with the rational study. So I think PDL1 scoring, as I said, I think various types of scoring they use. But coming to the concordance, I think most commonly the concordance with TAP scoring and CPS, both are more concordant. When TAP is more than 10 and CPS is usually considered as more than 10, or if it is less than 10 and TAP score also comes less than 10, the concordance rate is about 90%. Whereas TAP and when we use TPS scoring, the concordance rate falls down to about 70 to 75%. So most commonly CPS and TAP usually they can be used interchangeably. So regardless of the what method of PDL1 scoring we are using across trials, we have seen there is clinical benefit is observed. Those patients who had even more than PDL1 or TAP scoring more than 10, or a CPS of more than 10, or TPS or total count score of more than 1% or less than 1%, and those patients, even those who do not have a PDL1 scoring, so clinical benefit is seen in terms of overall response rate when we used immunotherapy in all these patients. So the same goes with even the overall survival benefit. So irrespective of the scoring we use, and more than 10 or less than 10 or whatever the score is, so patients have been getting benefit even with respect to overall survival benefit, regardless of the scoring system what we're using right now in our practice. I think I'm done. Thank you.
Thank you so much, sir, for this wonderful session. Now, again, inviting Dr. Sandeep KS, medical oncologist, Raichur, to begin with the next session. Over to you, Dr. Sandeep.
Hello, ma'am. Are you going to share the slides, ma'am?
Sure, sir.
Good afternoon again. Once again, I thank Dr. Lepak sir and also the NatCon for providing this opportunity to present today's seminar. So we'll discuss regarding erdafitinib and its role in mainly biliary tract tumors. So erdafitinib is a first-in-class FGFR inhibitors, which is a oral tablet approved in BTS as well as urothelial carcinomas. So we'll move to the next slide, ma'am. There is a slightly mismatch in the slides. Okay, we'll move on to the next slide, ma'am. Next slide. Next slide. Next slide. Next slide. Next slide. Next slide. And next slide. One more slide. Next slide. Next slide. So we'll begin with this erdafitinib. See, erdafitinib, which is mainly a FGFR inhibitors. FGFR is a fibroblast growth factor receptor, which is mainly activates the. It will be there in all the RAS, RAF, PIK3 pathways, all the pathways, signaling pathways, which actually helps in cell proliferation, signaling, and angiogenesis. These are the pathways which actually promotion of this FGFR receptor leads to this tumor progression. So blocking this FGFR receptor prevents the mainly the cancer progression. So there are 4 FGFR receptor: FGFR 1, 2, 3, and 4. So this erdafitinib mainly inhibits all the 4 FGFR receptors, which is mainly important pathway in case of urothelial as well as biliary tract tumors. So it's used in both advanced biliary tract tumors. After progression of initial chemotherapy and immunotherapy, patient should be not a candidate for immunotherapy to use this erdafitinib. It should be progressed after chemotherapy and also immunotherapy. Then we can use this erdafitinib, which is a FGFR pan FGFR inhibitor. It inhibits both FGFR 1, 2, 3, and 4. It comes in 3 mg, 4 mg, 5 mg tablet. This erdafitinib. So it is to use this oral tablet, patient should not have any PD-L1 positivity, and they should not be a candidate for immunotherapies. So next slide. Next slide. The important thing about dosing of this erdafitinib, if you see this erdafitinib dosing, initially we'll start with the 8 mg, that is 4 mg 2 tablets will use initially, and the dose we have to titrate based on the phosphate level, serum phosphate level. We'll check this serum phosphate level between 14 to 21 days, and also other side effects of these erdafitinib. So if at 14 to 21 days, if serum phosphate is normal and there is no ocular complications, then we can increase this dose to 9 mg. That is, instead of 4 mg 2 tablets, we'll go with 3 mg 3 tablets. It is actually continuous dosing. So after 14 to 20 days, we can increase it to 9 mg. And if there is vomiting occurs, the erdafitinib should be the next dose should be taken at the next day, and the treatment should be continued until the disease progression. So next slide. Next slide. See, erdafitinib in a biliary tract tumor, we have almost there are 2 to 3 FGFR receptor inhibitors are there. Among them, erdafitinib is also one. So next slide. Next slide. We'll go to the toxicity slides. So we'll stop this here. So erdafitinib, which is also one of the FGFR inhibitor. We have other FGFR inhibitor approved in biliary tract tumors, which are mainly futigatinib and pemigatinib and this erdafitinib. All the 3 are approved, but the this specific condition of this erdafitinib is which is used in almost any alteration of this FGFR 2-3 alterations. Others are more specific towards the FGFR2 mutations. This FGFR mainly we analyze through either fish or NGS testing. So the side effects of this erdafitinib, it has mainly dry mouth, mainly mucositis, stomatitis, and dermatitis, alopecia, and also dry skin and hand-foot syndrome. One more important side effect of this erdafitinib is mainly central arterial occlusions. So we should monitor even up with ophthalmic examination. There is one more important is hyperphosphatemia. See, with this blockade of this FGFR receptor, the phosphate excretion also will be blocked, and also there is a reabsorption of the vitamin B12 absorption with this blockade. So there will be hyperphosphatemia with this FGFR receptor. And patient can also have other important side effects like diarrhea and the nail toxicities. So these are usually managed with this local treatment like for dry mouth salivary stimulations, and for stomatitis we'll use with the saltwater gargling or any mouthwash gargling. And for alopecia we can use minoxidil, and for dry skin we can use moisturizers, and for hand-foot syndrome also we can use moisturizers, urea creams, and salicylic acid. And for eye disease, we have to monitor before the eye disease sets in with the regular ophthalmic examination. And hyperphosphatemia, we will, as I discussed, that we should check for serum phosphate levels, and also nail changes we should be checking. So the common side effect is nail disorder first, followed by skin disorders, eye disorders, and central serous retinopathies. These are the common side effects of this erdafitinib. Next slide. I have discussed that the dose modification is based on the phosphate level. See, we'll usually start with 8 mg daily. That is 4 mg, 2 tablets daily will start. At 14 to 21 days, we will check the serum phosphate level. If it's less than 6.9 milligram per deciliter without much side effect, we can continue with the higher dose, that is 9 mg instead of 8 mg. If it is hyperphosphatemia is between 7.8 to 8, then we can continue with the regular dose. If it's more than 10, we should withhold this erdafitinib. When the phosphate level comes back to less than 7 milligram per deciliter, then we can restart this erdafitinib at the dose of 8 mg per day. So this is the dose modification based on phosphate level. Next. See, if it's more than 10 milligram, withhold. When it comes back to 7 milligram, we'll restart this one. So serum phosphate, or if there is any life-threatening consequences, that time we'll continuously discontinue this erdafitinib permanently. Next slide. So one more important complication of this erdafitinib is central serous retinopathy. So FGFR inhibitor with MAP kinase, which is also there in the mainly vessels of this central retinal vessels, which will lead to this blurring of vision, wavy lines, and those other retinal complications. So usually the median time to set up the appearance of these side effects is around 50 days, which are mainly self-limiting without much improvement. With self-limited with improvement on holding the therapy, it will again we can reverse those complications. And the surveillance with ophthalmic examination and the mainly ophthalmic pressure monitoring testing monthly for almost first 4 months, then followed by every 3 months we should do this ophthalmic examination to early detect these ophthalmic complications. So mainly grade is the management of the central serous retinopathy with this erdafitinib is the grade 1 is it should be asymptomatic or diagnosed observation only. That time we can withhold until the results and restart at the first dose, that is 8 mg dose. If grade 2, that is visual acuity is 20/40 or better or less than 3 lines of decreased vision from the baseline, we will withhold it, and when the results we can restart it at the first dose. If it's grade 3, that is visual acuity worse than 25/40 or more than 3 lines of decreased vision from the baseline, we can withhold it until it resolves and resume at the second dose level. That is, we'll reduce the dose to from 8 to less than 8, will reduce and start the dose. And if it's a grade 4 toxicities, that is 20/200 visual acuity and the worst in the affected eye, then we'll permanently discontinue this adaptatives. Next slide. So the management of this CR central mainly retinal occlusion in the adaptive clinical studies, if you see the dose interruption is in that study, only 8% of patients require dose interruption, 13% required dose reduction, only 3% required permanent discontinuation of this adaptive. So even with this complication also, we can easily use this adaptive. Next. And the cutaneous toxicities, as we already told that before, so it has a nail complication, nail toxicities like mainly onychomycosis, paronychia. In such cases, we can use topical or oral antibiotic, and there can be a treatment way can improve that one. So in such a case, avoid prolonged contact with water or repeat trauma while using this adaptive, and use of topical emollients like and also loose fitting cloths can prevent these nail complication. And avoid use of nail polish or nail biting and manicuring. Those nails should be avoided while taking this oral tablet. And also Epsom salt soaks and vinegar soaks can be used to prevent these nail complications. And other complication is hand foot like any other tea case. So first is prophylactic removal of hyperkeratotic areas using moisturizing creams with more than 10% urea, and avoid any lotions with alcohols or cushions, cellulized areas, and limit contact with chemicals, and wear gloves in a sunlight. And also we can manage with urea creams, topical creams, and also moisturizers and antibiotics, and to prevent infections. And also treatment breaks can reverse these cutaneous toxicities. Next. So in a specific population like pregnancy, it's not recommended. The adaptive should not be used in pregnant women or lactating women also. So on females and males of reproductive age also, it is not recommended. It can cause infertility. And also pediatric age, it is not recommended. So it should be used in a non-pregnant or non-lactating or not non-reproductive patients, and also non-pediatric patient, adult patients we should use this. So mainly adaptive in this adaptive in biliary tract tumors, if you which is usually used in a second or third line. You have already seen that will in a first line will use with chemotherapy, background chemotherapy, either like Gemcis with the durvalumab or Gemcis with the pembrolizumab. And in a next slide, when it progresses on that one, we'll test with this either broad-based NGS testing. Mainly we'll use RNA-based to check for even fusion of this FGFR or alteration of this FGFR receptor, or we can use FISH also. So in such a case, we can use this when the FGFR alterations of FGFR 1 to 3, we can use these adaptive oral tablet. Next slide. Go to the last slide, sir. Hello?
Next slide, please. Go to next slide, last slide.
Okay. So this is the slide is for urothel, but I will talk regarding this biliary tract tumors. See, FGFR gene fusion rearrangement are important treatment in case of biliary tract tumors, which is mainly second or third line we'll use in a subsequent lines. So this is, there are 3 approved. One is futigatinib, pemigatinib, and erdafitinib. So these 3 are the important FGFR inhibitors, but this erdafitinib is a oral tablet which is used in FGFR alterations, not just the fusion. You can use in alterations also, which is giving good overall response rate of almost 44%, and decent DFS of 8 to 11 months. So based on Ragnar trial, which is a phase 2 trial, single arm phase 2 trial, based on that, which is approved in a biliary tract tumor. So with this, I will conclude my presentation. And thank you for Lepakshi sir and the team, as well as NATCON for providing this opportunity. Thank you.
Thank you so much, sir. Now inviting Dr. Rijal Rajan, consultant medical oncologist, hemato-oncologist, Bharat Hospital and Institute of Oncology, Mysore, to begin with the last session. Over to you, Dr. Rijal.
Thank you. Thank you, Lepakshi sir, for this opportunity.
Thank you. Dr. Rajil Rajan from Clearmedi Radiant Hospital. He's
Yes.
our medical oncologist from Mysore. Welcome, Dr. Rajil Rajan.
Thank you, sir. Thank you, sir. So I'll start with the presentation quickly. I'll share this. My screen is visible, sir.
Yes, sir.
So I'll be talking about personalizing CIND prophylaxis, that's chemotherapy-induced nausea vomiting prophylaxis, lessons from my risk trial. So basically, we are in an era of personalized medicine, and whether this personalization is needed for CIND prophylaxis, that I'll be discussing with the help of my risk trial. So in our routine practice, how we routinely prescribe chemotherapy-induced nausea vomiting prophylaxis regimen is based on the emetogenic potential of chemotherapy drugs. Like it is divided into highly emetogenic, moderate, low, minimal. So based on this, there are, regimens, antiemetic drugs which is used. Like most commonly class of drugs which we use is, 5-HT3 receptor, NK1 receptor antagonist, dexamethasone, and olanzapine. A combination of these is used to prevent CINV in highly emetogenic, moderately emetogenic, low and minimal. So one thing which we usually don't consider is patient-related risk factors. We base our, prophylaxis based on the guidelines which divide these drugs into these types actually. So do we really have to look into these risk factors, or it is just one size fits for all? That is what I'll be talking in this topic. So basically, what common risk factors which we need to consider while prescribing CINV prophylaxis is, female gender, young age, history of chemotherapy, anxious personality, minimal alcohol use, history of emesis during pregnancy, and history of motion sickness. So we have guidelines, many guidelines like NCCN coming up, ESMO, MASCC, all these guidelines coming up with this classification, high, moderate, low, minimal, emetogenic potential of chemotherapy drugs. So chemotherapy drugs are grouped in one of these based on their emetogenic potential, and we have recommended treatment like prophylaxis regimen for this. Like if it is high, we use a regimen where NK1 receptor antagonist, 5-HT3 receptor, DEXA, and olanzapine, all the four drug classes are included. So highly emetogenic, we don't have any issue. It is like, all the possible emetogenic anti-emetic drugs are included. The issue and problem comes in treating with moderate emetogenic, emetogenic drugs, because here guidelines are also divided basically. And that brings in the question whether one size fits all in the modern emetogenic setting, because confusion starts in the moderate emetogenic setting, not in the highly emetogenic setting, because guidelines are divided, what to use, how to use basically. So moderate emetogenic potential or emetogenic drugs, in some guidelines where, where carboplatin AUC more than or equal to 4 is used, they are recommending to use NK1 receptor antagonist. Same with oxaliplatin. NCCN guidelines recommend if there are any high risk factors like, patient related risk factors, they recommend to use NK1 receptor antagonist. So in this way, the guidelines are divided, and also some drugs like, trastuzumab deruxtecan, which is highly emetogenic based on NCCN guidelines, are in moderate emetogenic this thing in other guidelines. So guidelines are divided. There is confusion in treating moderate emetogenic potential, whether we should really use NK1 receptor antagonist, or can we really skip NK1 receptor antagonist and just go with 5-HT3 and DEXA. So same like what I have already discussed, the guidelines are divided here. NCCN says, you have to look into risk factors, and if any of the risk factors are present, you have to add NK1 receptor antagonist. MASCC, ESMO strongly suggest adding NK1 receptor antagonist if, a regimen contains carboplatin AUC more than or equal to 5 if oxaliplatin is used in women less than 50 years, TDXT or sacituzumab govitecan. ASCO recommends carboplatin AUC more than or equal to 4, then we are supposed to use NK1 receptor antagonist. So we can see in moderate hematogenic chemotherapy regimens, the guidelines are divided and we really don't know which one to follow, or should we really get into that personalized side and look into risk factors which will help us, objectively add NK1 receptor antagonist to prevent CINV, because that is one of the side effects, especially delayed nausea, which should be prevented aggressively. So to address this, we have a phase 4 trial, that is MyRisk trial, where personalized antiemetic prophylaxis with NEPA was used for patients at high risk chemotherapy-induced nausea, vomiting, receiving moderately emetogenic chemotherapy. So moderately emetogenic chemotherapy regimen were used in this study, and from regimen-based prophylaxis, this trial tried to address the risk factors based, personalized means patient related risk factors based, treatment planning, CINV prophylaxis planning, whether, adding NEPA will help these patients achieve, better CINV control rates. So the background is what this study tried to analyze was, so there are two groups basically. Moderately emetogenic chemotherapy drugs were used. In that, they have found out, CINV risk score was more than or equal to 13 were included. That means based on 6 risk factors, which is already been explained, like young age, less than 60 years, expectation of nausea and vomiting, motion sickness, and about to receive platinum or anthracycline chemotherapy, experience nausea or vomiting in prior cycles. All these risk factors has been included, and they've used an algorithm to calculate the risk of CINV. And if that risk is more than or equal to 13, those patients were included in this study, and moderately emetogenic chemotherapy drugs were used. So NEPA with DEXA was compared with standard of arm was 5-HT3 receptor plus DEXA across 3 cycles of moderately emetogenic chemotherapy drugs. So obviously the question comes, why NEPA? So it's a fixed combination of netupitend and palonosetron. So netupitend is an NK1 receptor antagonist, and palonosetron is a second generation 5-HT3 receptor blocker. Both has its own unique pharmacological profile. Netupitend has a longer half-life. I'm comparing this with the aprepitant, the initial, drug which came in market. Both these drugs have significantly changed the way we treat, the way we do prevention of CINV. Once this NK1 receptor antagonist came into market, it just changed. Nowadays we don't routinely, counsel patients that vomiting is a side effect because of this drug class. NK1 receptor antagonist, where aprepitant and netupitend plays a very important role in prevention of CINV. And netupitend compared to aprepitant has a longer half-life, almost around 90 hours, and higher receptor occupancy. So it binds to the receptor for a prolonged duration of time, and that will be translated in preventing delayed nausea, vomiting to a much better compared to aprepitant. That is one of the pharmacological advantage which netupitend has over aprepitant. And palonosetron, again, when we compare it to the first generation 5-HT3 receptor blockers like ondansetron, it has a very long half-life and it is much potent, and it has a 30 to 100-fold affinity for 5-HT3 receptor, and there is no QTC prolongation which is seen with the ondansetron. So this combination really works wonder to prevent acute as well as delayed nausea, vomiting, and studies have supported this NEPA, but it is again mixed. Some studies, some meta-analysis have shown, NEPA is better compared to aprepitant, especially in terms of preventing delayed nausea, vomiting. Again, translating from its unique pharmacological profile of longer half-life and higher receptor occupancy. So this MyRisk study, it was a phase 4 and open label randomized multi-center multinational trial. Multiple countries were included in this trial, and patient receiving moderately emetogenic chemotherapy, and that has been divided into high risk. Only high risk MBC patients were included, randomized 1:1 to NEPA and DEXA compared to any 5-HT3 receptor antagonist plus DEXA. So primary endpoint was complete response across 3 consecutive cycles of MBC. Complete response means no emesis and no rescue medication in the first overall, like both acute and delayed phase. That is the first 5 days. Secondary endpoints during the acute, delayed, and overall phase across 3 cycles: CR, complete protection, no emesis, no nausea, no rescue medication use, and also quality of life. That is NIDL assessed using FLY, and safety was also reported. Looking into the patient demographics, mean age was 62 years and all this, the characteristics were well balanced in both the arms. Colorectal and lung cancers were the most common cancers. And among the regimens, oxaliplatin containing regimen and carboplatin containing regimen constitute the maximum numbers. So moving on to the results, primary endpoint, that is complete response across 3 cycles. Overall phase. So what we can see here is, so almost 8% benefit is seen with the use of NEPA. That is 8% patients benefited above this, the conventional arm when we use NEPA. So that is what, these patients did not experience any nausea, vomiting for the first 5 days of the entire 3 cycles. So significantly higher with NEPA, p-value is also significant, and that benefit has been seen. So primary endpoint has been achieved in this trial. Coming into the secondary endpoints, so complete response across 3 cycles, acute and delayed phase. So here we can see in acute phase, the benefit is not much. We can say it is similar, but the significant difference what we see, in complete response is in delayed phase. Almost like 9% benefit when we add NEPA. So 83% patients achieved complete response when NEPA was given versus 74% in the conventional standard arm. So the difference is significant, and not in acute phase, but in delayed phase. No nausea rates. So here we can see based on cycles, we can see delayed phase. Okay, in cycle 1, delayed phase, and in overall, we can see there was a very good improvement. No nausea rate. 66% patients did not have nausea in delayed phase in cycle 1 compared to 55%, almost 10 to 11% improvement. Same with the overall phase. Cycle 2, cycle 3 also, this has been maintained actually. So patients suffering from nausea, especially the delayed nausea, was significantly less compared to the conventional arm, which is one of the very difficult side effect we have to manage. Sometimes we usually oversee this because nausea, delayed nausea especially. So that has been reduced. The benefit was seen in delayed nausea across all the 3 cycles. So one more secondary endpoint, efficacy in MEC patients for whom ESMO or MASCC does not recommend NK1 receptor antagonist. It's a subgroup analysis. Estimated CR, that is complete response, and no nausea rates were higher in the NEPA group than the standard arm during delayed and overall phases in the subgroup analysis. So again, this subgroup analysis reinforces the fact that even in moderately emetogenic patients, we really need to look into the risk factors. If this patient has high risk factors, definitely that patient should receive, NK1 receptor antagonist, NEPA, which will help in preventing delayed nausea, and overall, control rates are better, especially if there is risk factors and we are giving moderately emetogenic chemotherapy drug. So this subgroup analysis again reinforces that part. So what they did, not only just the control rates or nausea rates, they tried to see into the quality of life aspect, whether, this prevention of nausea, vomiting is really transforming into better quality of life. So NIDL, that is no impact on daily living. So around in the total domain, that is nausea and vomiting, 80% patient were able to live a normal routine, normal life without hampering any of their, life activities. In the nausea domain, 76% were able to live a normal life during this phase compared to 67%, which is also like significant. Numerically, total domain is on higher side, but not statistically significant. Again, with vomiting domain, again, we can see, 92% patients had a normal routine life. Their quality of life was not impaired. They had a very routine life, all thanks to the NEPA regimen, where they were not having nausea, vomiting, and they were having a better quality of life. Safety concerns were not there, which is expected. Compared to standard of care, there was no difference in the safety concern, no significant difference as such in adverse effects. So coming into conclusion, like I said, we are all in the era of personalized medicine. So in CINV prophylaxis also, do we really need to look into the personalization, look into the risk factors, and then, aggressively add NK1 receptor antagonist, add NEPA, which will help in, preventing this, especially delayed, nausea, vomiting. So I am very much convinced with this trial because, moderately emetogenic chemotherapy drugs, there are, confusions whether, we really have to add NK1 or can we really avoid. Routine practices when we use carboplatin regimen and oxaliplatin, we usually add the NK1 receptor antagonist. So not only that, I think this should be extended to the risk factors also, young age, females, anxious nature. When we talk, we'll understand. So I think there's no harm in, aggressively managing, prophylactic regimen, aggressively giving prophylactic regimen so that, we can really prevent, the CIM, which is one of, once it happens, it is a really bad, especially the nausea component. Maybe vomiting we can control better, but delayed nausea is really a bad side effects. And this study, gives us confidence, to prescribe these NK1 receptor antagonists to this subset of patients, who are high risk for chemotherapy-induced nausea, vomiting. And study reinforces the fact with, primary endpoints and secondary endpoints where, complete response was observed, even no nausea, quality of life, all that has been, in place. So clinical implication, definitely this trial, even though it's a phase 4 trial, multi-center, multinational trial, that just reinforces the fact that, personalization is also needed in CINV prophylaxis, not just in the treatment of cancer, because at least we shouldn't, hamper the quality of life with delayed nausea to a patient. Because acute, we don't usually see in our routine practice, acute nausea, vomiting is very much in control with the regimen which we use for prophylaxis. But delayed nausea, especially moderately emetogenic, where the guidelines are divided, where we don't really know, giving NK1 receptor is over treatment or is it under treatment, we really don't know. Using these risk factors will help us, give little confidence to, include these NK1 receptor antagonist and in that NEPA, because NEPA has superior the pharmacological superiority over, aprepitant on controlling delayed nausea, vomiting, that really helps. So in my clinical practice, after reading this, I am definitely going to include this personalization, NK1 receptor antagonist. And if cost is not an issue, definitely NEPA will be my go-through drug of choice for NK1 receptor antagonist. Thank you, sir.
Thank you so much, sir. Now, again inviting our program convener, Dr. Lepakshi Kuruba, Senior Consultant Medical Oncologist, Narayana Health Mysore and Karunaru Cancer Clinics, Karnataka. So, over to you for presenter closing remarks.
Thank you, Manya. First of all, I would like to thank all our esteemed faculties for their insights on recent advances in the GI oncology and as well as esophageal cancer management. And starting from our Dr. Ullas Paga, he very well explained about the recent advances in the surgery. So I would like to thank him for his hard work he made to share his knowledge to the our audience. And I also would like to thank our Professor Dr. Vishwanath S. for excellent presentation on D-flat. It is very useful for our audience. And again, Dr. Sandeep KS, 2 sessions was excellent. Thank you, Dr. Sandeep, and also Dr. Abhilash, medical oncologist. He given very good insights on immunotherapy, especially tislelizumab in esophageal as well as the gastric cancer. And last, Dr. Rajil Rajan very nicely presented about the CANU prophylaxis with the NEPA and DEXA. Excellent presentation, Dr. Rajil. I would like to thank you. And uh, I also would like to thank our academic partners, Glenmark Pharmaceuticals, AstraZeneca Pharmaceuticals, Zydus, and Natco Pharmaceuticals for their valuable support for this academic session. And last but not the least, Origin Conference Management, led by Dr. Tarun Mathur and team for coordinating with all the academic partners and the esteemed faculties very well. And audio visual things also they made very well. Thank you for them also. I hope this webinar is very much useful for our residents and also consultants. So it will be the practice changing things in our oncology. And with that, I conclude my remarks. Thank you, one and all. Good night.
Thank you so much, Dr. Lipakshi, and all the doctors for your valuable time and active participation in today's scientific webinar on multidisciplinary approach in GI and ESCC cancers. We sincerely appreciate your presence and engagement. Thank you so much.
Thank you, Manya, for excellent organization.
Thank you, sir.